Hi, everyone. My name is Ailey Kalapilla, and I am an infectious disease doctor that works with the Atlanta Harm Reduction Coalition. I did my medical school at Penn State, and then I actually did my residency and my infectious disease fellowship at the University of Washington in Seattle, after which I moved to Emory, where I'm currently faculty at the Emory School of Medicine. I do most of my clinical time at Grady, which is Atlanta Safety Net Hospital, doing both inpatient and outpatient HIV and general infectious disease care. And I also care for hepatitis C, mono, and co-infected patients. And then for the last year, I have been working with the Atlanta Harm Reduction Coalition basically to sort of help them with their PrEP program, which they're collaborating with the Fulton County Board of Health, but then also to help develop and implement their HIV treatment program, as well as their hepatitis C treatment program as well. So I've been asked to talk a little bit about how to bridge gaps between academic medicine and community-based organizations. And the focus in particular is going to be on rapid antiretroviral therapy. And so I just wanted, the first slide that I have, and I only have 2 slides, is to talk a little bit about just rapid ART. And so the DHHS, which is sort of the National Antiretroviral Guidelines for HIV management and treatment, was last updated, or this section was last updated in December 2019. And it actually talks about initiation of antiretroviral therapy. And if you can see in the first paragraph, what it says is that the panel recommends that ART be started immediately for patients who have a diagnosis of HIV or soon after the diagnosis. And really the reason for this is that a lot of data has shown that if you can start patients fairly quickly on antiretroviral therapy, you are able to keep them linked and retained in care. So essentially you're able to move them and keep them within the HIV care continuum. And so the next slide is actually sort of highlights certain things about rapid ART, and I have the citation up so you can always go to it. It was actually a recent editorial that was written in Clinical Infectious Disease Journal, just published last week by some of my colleagues. And they give a nice review about rapid antiretroviral therapy. And what they essentially say is that rapid ART, essentially, like I said, means that you start initiating antiretroviral treatment as soon as possible after the diagnosis of HIV. And in an ideal world, that's the same day of diagnosis, but most metrics will say within 7 days of diagnosis. But nationally, I think there is a push to try to do this within the first day, if not within the first 72 hours of someone receiving a diagnosis of HIV or engaging into care, especially for the first time. This is only a more recent accepted phenomenon. Historically, we didn't used to do this so much, and the main reasons for that were primarily because of drug toxicities. Many of the drugs had a low genetic barrier to resistance, meaning that if patients were not taking it consistently, that they would get resistant to the drugs, and then we just had very few options to treat them with. And of course, finding funding for these meds, which, as I'm sure many of you know, can be very, very expensive. And I think that a lot of that thinking has now moved over the last several years. And we know now that there's really no reason to delay it anymore. And we have plenty of data from multiple randomized clinical trials, both nationally and internationally, that have shown that when patients receive a prescription within the first day or first 72 hours, they are more likely to stay linked to care. They're more likely to have a shorter time within which they suppress their viral load, which is the main goal for antiretroviral therapy. And then also, they're able to stay retained in care and have viral suppression for a longer amount of time. So all of which are very, very good things. And so, rapid ART is not something that it would be ideal, but obviously there are certain issues that come into play when you try to institute such programs. And it really means that you have to have a lot of collaborative relationships and good relationships with people at the testing site. So when the patient first gets tested, and then once they get tested, then how do you eventually link them to finally getting their prescription in their hand? And so this is where linkage coordinators and social workers and case managers come into play in order to sort of make that journey for patients from the point of testing to the point of receiving a prescription a much smoother journey with fewer barriers. Obviously, you need to be able to have sustained access to antiretroviral therapy. And so this is another situation where wherever they're getting their prescription from, it should be a place where they can continue to get that prescription. They can get renewals. Antiretroviral therapy is still expensive, and so many patients may be or underinsured. And so in order to be able to continue getting ART, they need to be linked to adequate payer sources, and also linked to a proper clinic so that they can continue to get clinical care. You need to have enough staffing of clinicians in order to be able to see the patient so that they can give them the prescription and do an initial assessment and history and physical on the patient. And you obviously need to have some sort of lab facilities as well so that patients can get labs done fairly quickly, because you need to be able to monitor the patient both for toxicities that may be due to the drug, and also whether or not the treatment is successful in this patient. And then in order to keep that patient retained in care after you give them that initial prescription, you need to have ongoing patient navigation, education, and you need to have them linked to teams where they can work to keep the patient retained in care, because the patient may have multiple psychosocial barriers that could prevent them from staying in care. The main barriers, of course, to rapid ART initiation are that many clinicians might still be reluctant to do it, again, because they have either just a lack of understanding of how ART is done. They may not realize that the data actually shows that ART, rapid initiation, does work for the vast majority of patients who are engaging with HIV care for the first time. And of course, as you can well imagine, since there are multiple stops between the patient's testing to when they get a prescription to when they stay in care, there are multiple barriers that can come in the way, and multiple systems level barriers that can occur at an organizational level that can prevent a program from initiating a rapid ART program. That's sort of the main highlights that I wanted to talk about, but I can also talk a little bit and answer just some questions about the work at Atlanta Harm Reduction and how rapid ART works with that.
Thank you so much. So can you share with us, Dr. Kalapila, how is rapid ART different than from regular care? What were patients expecting receiving regular care that's now, this is obviously shorter time. So can you talk to us about what was that regular care look like, and how is it now different from this rapid ART?
Sure. So, I can even just talk about my experiences even at Grady, even the last 6 years that I've been here in Atlanta. I think when I first started here 6 years ago in 2014, it was unusual, unless someone had an extremely urgent or emergent indication to start antiretroviral therapy, like say there was a pregnant woman with HIV, or someone who had an advanced opportunistic infection, which needed them to start ART like today. More often than not, what would happen is that the patient would be discharged from the hospital or come to the clinic, and they would enroll, and it would probably take maybe a week or a week and a half, depending. Say they happen to come just before a long weekend, it would probably take them 5 or 6 days or even a little bit longer to see a provider in order to get a visit in, and then of course, sometimes what would even happen is they would come in to enroll in a clinic. They would wait maybe a little bit over a week to see a provider. When the provider sees them, they would do labs. And then, the labs will take another day or two to come back, and then the prescription comes in. So there was always probably a lag time of maybe anywhere between a week to maybe even 2 weeks for a patient to actually get a prescription of medications. So I think that way rapid ART has drastically changed. And a lot of that has to do with, we have, I think there's a recognition now that it becomes increasingly important to start ART sooner rather than later. The meds are also much safer than they used to be. And so I think everyone recognizes that if we can get patients a prescription that same day or within 72 hours, they're much more motivated to actually stay in care and stay engaged in care for a longer period of time.
Great, thank you. And so is every patient who is identified through, you mentioned testing sites and outreach sites, so is every patient who's identified with living with HIV, whether they are newly diagnosed or have fallen out of care, does everyone actually is a good candidate for rapid ART, or are there candidates that, or is there a system where you would have to kind of say this is a good candidate and that person will not fit into the criteria of rapid ART?
Yeah, so I think this is where certainly the model that we have, Atlanta Harm Reduction, is helpful. But in general, in order to have rapid ART set up at any site, you would need to have a provider who's able to see and assess the patient. And so when the provider gets the history from a patient, because the patient's not just getting tested and then immediately getting a prescription, someone has to actually talk to the patient. So when the medical provider talks to the patient, they can get a sense for what is their baseline, like do they have other comorbid medical conditions? Do they, for instance, if they're known to be a dialysis patient, or if they have severe kidney disease and the patient's able to tell you that, then they may not necessarily be eligible for ART. Do they have a history of significant ART experience? So this is not the new patient, like, oh, I just found out I have HIV and now I need medications. This might be someone who's been out of care for 5 or 6 years, who comes in, and then you hear their history, the provider hears their history and realizes that this patient has a history of being exposed to some of the newer drugs that we have, that and may not have taken the meds consistently. It might have had resistance to the medications. There are some patients, by the time they seek care, it's very clear, either when you examine them or you hear their history, that they probably have very advanced HIV. And so in which case, you can sort of hazard a guess that their T cells are probably less than 200. And if they have specific signs or symptoms, so one of the things we sometimes worry about is if patients have occult central nervous system infections. Those are one of the few times that, and also if someone might have pulmonary TB, where we may opt to delay antiretroviral therapy because until we actually treat the acute infection, because there's a little bit of danger with starting ART in the setting of these like certain infections. There's a little bit of a danger in starting ART almost immediately, and we may have to delay it for about 2 or 3 weeks, but you should be able to link the patient to care. So I think those are the certain specific times when we may have to, a person may not be eligible for rapid ART initiation. But overwhelmingly, if it's someone certainly who's a new diagnosis, or someone who maybe historically, like, I got diagnosed 20 years ago and I took meds 10 or 20 years ago, and then I felt well and I stopped taking it, and now I'm back in and I'm ready to get into care. More often than not, those patients can still get the rapid ART drugs, because some of the drugs that we use for rapid antiretroviral therapy initiation are some of the newer agents that we have on the market that even patients who've been on older regimens may not have been exposed to, so the odds of them having resistance to those drugs would be quite low.
Okay, wonderful. And you mentioned your experience with patients at Grady and then also at Atlanta Harm Reduction. What have your experience been in the past 6 years that you've been doing work in Atlanta, as far as whether rapid antiretroviral therapy, obviously in the guidelines and, in data, it shows that it's effective. But when it comes to your experience, has it been helping keeping patients in care and reduce falling through care?
Yeah, I think definitely. I can only speak anecdotally, but I do feel like when I see patients for the first time, either at AHARC or at my Grady clinic, I think that patients are much more motivated and actually more excited because they've actually, they are motivated enough to come and seek care because they're concerned about their health. And so I've definitely had experiences where I think people come in and then they're just happy when all of a sudden they're like, oh, I can get my meds today. Okay, that's great. Or I can get it tomorrow, and so they're very, very excited. And I think that it really also, I think, increases or strengthens strengthens the bond between the patient and the provider, because I think patients realize then that you have a provider who's advocating for you and feels like, yes, this is important. This is an important part of your health that needs to get managed and treated. And I think that also helps to sort of keep them engaged and kind of stay in care. And then one of the other things with the rapid ART is because there are so many steps between when they come in to get care and they get their prescription, that's sort of built in. So they have a linkage coordinator or a linkage specialist that works with them at AHARC. At Grady, it's like they have a care coordination team or a social worker or someone who works with them. So it's sort of nice because then they kind of come in with not just a physician or a nurse practitioner or a PA that works with them, but they have, you may have a nurse that works with you, you have a social worker or linkage coordinator that works with you. So you actually have sort of a very comprehensive team behind you and a pharmacy as well. So that you are addressing different aspects of the patient's overall well-being. So not just taking care of the medical side of things, but you also have like a social worker helping you find housing or dealing with food insecurity or whatever it might be that many of our patients go through that impede their ability to stay adherent to their medications or stay on their medications. So the fact that as a result of this rapid ART model, both at AHARC and Grady and multiple clinics nationally and internationally, these patients not just have medical providers, but they also have like a much more holistic team behind them to kind of help them stay engaged in care, I think is kind of huge in keeping them in care in the long run.
Okay, wonderful. And so you also mentioned, during your talk about those patients who may not qualify for rapid ART because of pulmonary TB, or they've been maybe like drug resistance is like a fear. So can you tell us the model that you've implemented within the AHARC clinic in then linking them into a kind of longer term care that is also more extensive and can, help them address many of these other issues, such as like pulmonary TB, if that's the case?
Yeah, so I think definitely at Atlanta Harm Reduction, it's been helpful because it's allowed me, I guess, truly to sort of bridge this gap because, being in academics and having sort of this direct line to Grady and Grady's HIV clinic, but also as an Emory faculty member, and with Emory has multiple hospitals under its purview where people train at. So the VA is part of the Emory system, Emory Healthcare, obviously, and Grady as well. So I have colleagues in multiple different divisions. And I also, because I've now been here 6 years, also know other infectious disease doctors at Piedmont and other major hospitals in Atlanta. So that has been helpful because then when a patient comes to Atlanta Harm Reduction and say they need a higher level of care, either their T cells are less than 200 and or they have an opportunistic infection, I am able to get on the phone or work with a linkage team at Atlanta Harm Reduction to then sync to get them into to Grady, where they probably might have a little bit more resources and access to subspecialists. If they need to get admitted, we can work with, directly to the hospital, we can work with that. And then also, for instance, last week we had discussed a case where there was a patient who was eligible for VA benefits. It was easy for me to get on the phone with one of my colleagues and, talk to her. And she is one of the leaders in their HIV and hepatitis C program at the VA. And so because of sort of my other connections, I'm able to kind of link people or work with the linkage team to actually link people to other clinics where they may have a few more resources if patients are very complex and might need a higher level of care to deal with other conditions in addition to their HIV.
Thank you, Dr. Kalapila. And my last question for you is that this seems like wonderful. It definitely reduces time. It increases linkage and retention. What are some of the challenges that you have identified with rapid ART, if any?
Yeah, so I think probably the biggest issue that we kind of face with rapid ART is I think there's still this I mean, some of it is for many of the patients, certainly the patients that come to Atlanta Harm Reduction, who we know are uninsured, underinsured, and have multiple psychological and or social barriers that may prevent them from just engaging in care. I think the rapid ART, the issue with it is that you still need to go through hurdles that are there that exist at a much higher systems-based level in order to keep them in care. So one of the things that is in my slide is this talking about early and sustained access to ART. So we've fixed the early portion of it. We can give patients a prescription, but the sustained access, they still need to produce paperwork in order to get their Ryan White, which is what they need, or their ADAP, which is the AIDS Drug Assistance Program in Georgia, which pays for their medications if they do not have a payer source. And ADAP has to be renewed every 6 months, wherever they get their care, be it AHARC, Grady, Piedmont, wherever, they still have to renew their ADAP every 6 months. And that can be a barrier for some patients, and Ryan White has to be renewed annually. And certainly, I think more so now than ever in the setting of COVID, when many clinics are closed, many resources are much more limited in general. Patients who historically have always struggled with that aspect of kind of keeping up with paperwork or getting documentation are going to struggle even more, because they'd also just there's fewer people for them to interact with who can help them through this process of like, I need to go get an ID. I need to get my social security card in order to prove that I'm who I am. I have to get a birth certificate. I mean, for patients who are, who have limited financial, economic resources, who are out on the streets, it's just going to be hard for them to produce that paperwork. And ultimately, we need that in order for them to keep getting their medications and so that they can stay so that they can have their HIV well controlled and stay in care.
And Dr. Kalupila, although I said that was my last question, I do want to ask one final question, given that many of our conference attendees may be, they have certain services programs and other services around harm reduction. So they may have like a registered nurse or a mid-level provider within their site, but not necessarily an infectious diseases specialist. I know you've done this within AHARC. So what does telehealth look like and is it a helpful strategy when it comes to rapid ART?
I think telehealth can be useful. I think the way that we use it in Atlanta Harm Reduction is because I'm not there every day of the week. We have our advanced practice providers who can do a basic history and physical, and then we can discuss the case over the phone. So at least to have someone who has HIV expertise available, easily accessible on the phone, so that even if the provider who is like an HIV specialist or whatever is not immediately available to physically interact with the patient, the fact that someone is there, that they can actually like do a telephone visit with the APP and the patient is, I think, super helpful to at least then for someone to so that the APP can then discuss the case and then they can make a plan that's best suited for the patient. And so then this way also, if there's any concerns, it's like a patient who maybe not be eligible for rapid ART because maybe there's some concern about resistance, or I'm seeing this patient in front of me right now and they have this diffuse rash and I don't know what it is. I think these are all avenues in which telemedicine can really help. And especially now with iPhones and smartphones in general, we can at least even do video visits where we can at least FaceTime with the other provider and then see what the provider is talking about when they examine the patient. So I think that way telemedicine can be a super powerful tool if you don't have an HIV specialist on hand immediately to kind of to immediately assess that patient that you think that you would like to give an ART prescription to.
Thank you so much for your time, Dr. Kalupila.
Oh, thank you. It's been a pleasure.